Hello there, I'm Tony Meekum. So this is topic 3 in my current course, CBCT for the general dentist. 3 short videos I'm going to make for this topic. The first one covers what CBCT is, when we use it, and the part I really want you to understand for this is dose. The second video is going to be a quick tour of how we look at CBCT data, and then the third covers artifacts, your interpretation responsibilities, and a brief mention of other advanced imaging modalities. So I'm not trying, and we don't have time to make you an expert in CBCT in these 3 videos. That's a separate task. What I want you to understand is enough of CBCT to make sense of the cases that I'll show you throughout the course and to make informed clinical decisions on when to order one. All right, so what is a cone beam CT? Cone beam computed tomography. The name comes from the cone-shaped X-ray beam, as seen in this diagram here, which is different from medical CT where the beam is fan-shaped. The patient sits or stands while the X-ray source rotates around the head. So for the patient, it's just the same as a panoramic radiograph. Of course, we know it's a lot different. As it's doing this, it's creating several hundred cephalometric projections around the patient. And those are taken during a single rotation. The computer then reconstructs those into a 3-dimensional volume. And then that volume is what you're looking at when you scroll through a CBCT. You can slice through in any direction. You can rotate it. You can reformat it as a panoramic, an arch section, or 3D rendering, all from the same scan. All right, then quick comparison of 2D versus 3D, so 2-dimensional, including our panoramic radiograph. As far as image formation, they're both formed by X-ray attenuation as it passes through a patient. A weakness of 2D is shadows, overlap, image distortion, particularly with panoramic radiography. Weakness of 3D imaging is going to be artifacts, or the Achilles heel of CBCT, as I like to call it, and I'll talk more about that later on. Strength of 2D imaging is it's inexpensive. It's relatively lower dose, although you'll see that some CBCTs are not much higher or even equivalent for the ultra-low dose settings. And then the strength of 3D CBCT is accurate spatial resolution, so you're able to measure between different points. You're also able to see beyond structures, and so you're no longer hampered by overlapping of anatomical structures. And then just as far as nomenclature, a vocabulary point, in 2D radiography we use the terms radiolucent and radiopaque. Same concepts, hypodense is darker, hyperdense is lighter. And so when I'm going through a CBCT case in the course, I say a lesion is hypodense. What I mean is it's the same as saying radiolucent on 2D imaging. It's dark. X-rays pass through more easily, things like air, maybe soft tissue. Whereas if it's radiopaque, it's lighter on the image. It blocked out more of the radiographs, so bone, and particularly enamel or especially metal objects are going to be hyperdense. All right, so just the same concept, but different terminology because we're in 3 dimensions now. Oh, and here's our 2D and 3D Marios, just for fun. And so I probably have too many examples here of the limitations of 2D imaging. We have overlap, and so we have things look different than what they are in real life. Another example here. Interesting person there. Dog eating people at a beach. Oh, there's a nice one. Then I like this one. We're just about to have the 250th anniversary of USA, so this is a timely one. But on a 2D image, everything in the path of an X-ray beam gets superimposed. So a lesion behind the tooth might be hidden by the tooth. With 3D, you can just scroll past it and see the lesion. Also distortion. Can you imagine the jet streams being measured on the same image as the eagle's talons? They're probably not going to be proportional. So panoramic radiographs specifically distort things, and horizontally even more than vertically. So we covered that in topic 1. You can't reliably measure distances on a pano, but with CBCT, measurements are accurate. So limited views, and a 2D image gives you one view, while as CBCT, you can have any view you want. You can look through the axial, coronal, sagittal, or even oblique slices or custom angles. We have a slice that goes around the jaw and follows the curve of the teeth. So now you can see structures from angles that a 2D image could never show you. All right, now let's get to the why of CBCT, or when we use CBCT. I'll walk through the main clinical drivers that a general dentist needs to know. First of all, implant planning. This is the biggest one by far. So bone height, bone width, location of the inferior canal, location of maxillary sinus, density of bone. All these are things you need to know before placing an implant, and all things that CBCT shows accurately. There has been legal precedent that you should consider whether 3D imaging is appropriate before any implant planning. And I would say by default, from what I've seen from legal cases out there, for any implant planning, just get a CBCT. You may see something that you didn't anticipate. If something goes wrong, even if it's not related, then it's better to say you did it than you didn't. And I do think the dose trade-off is relatively low now as we go over dose numbers in a few minutes here. So 3 stars for that one. You got to know that one. All right, next one I want to talk about is endodontics. CBCT is huge for failed treatment, missed canals, vertical root fracture, periapical lesions that don't behave like typical inflammatory lesions, and even complex anatomy like dilacerated roots or anatomical variants. Sometimes these roots have more canals than you might imagine, and you might be able to detect with 2D imaging. So the American Association of Endodontics has a position paper joint with the AAOMR, my organization, on when CBCT is appropriate. And they typically say not for an easy case for first-line treatment, but even if it's first-line treatment and you have complex anatomy, they do recommend CBCT. Next one is oral surgery. So that's important for third molar planning, especially when the roots are close to the inferior alveolar canal or the sinuses, impacted teeth, supernumerary teeth, or pathology, surgical planning for cysts and tumors. And then TMJ here, CBCT shows the bony structures of TMJ really well. The condylar outlines, the fossa, the articular eminence, joint space, and any cortical changes. We'll see CBCT cases later when we get to TMD on topic 19 of this course. Airway and sleep, and this is a little bit controversial topic, but with increasing focus on sleep apnea and airway, CBCT can provide measurements of airway dimensions. This is growing in clinical relevance, especially for dentists working in sleep space. In my opinion, it shouldn't be that controversial. Nobody is saying that you're diagnosing sleep apnea, but it is a risk. So similar to taking the patient's blood pressure. If a patient has high blood pressure, hypertension, you're not diagnosing stroke or heart disease. You're just saying it's a risk factor. And this has been shown to be a risk factor for these things. All right, last one here, pathology characterization. When you see a lesion on a 2D image and you need to understand its extent, its borders in 3 dimensions, its effect on surrounding structures, CBCT is the next logical step. So we'll be looking at many CBCT cases going through the course where 2D images hinted at something and then the CBCT gave us the full picture. So it is really great for pathological characterization. And I would say keep in mind, when I'm suspecting pathology, I like to see the other side. So this is a case where I might default to a larger field of view than I would for some of these other things like implant planning. If it's a single impacted tooth, you can use a really small field of view. But for pathology, I like to default to a little larger. Make sure you get all the margins. And like I said, it's beneficial to see the other side as well. But not only characterization, but screening. We know that CBCT shows incidental findings all the time. We'll come back to that on the 3rd video when I talk about interpretation responsibilities. So the American Dental Association issued an advisory statement in 2012 on appropriate use of CBCT. The AAOMR, the Academy of Oral and Maxillofacial Radiology, has positioned statements on implants and endodontics. The European SEDENTEXCT guidelines are also widely cited, and all of those emphasize the same principle. Here I've kind of summed up what they say. It's always after dental and health history review and examination. Make sure the benefits outweigh the risks. Structures of interest are not going to be adequately captured with just 2D imaging. Always follow ALARA principles, meaning smallest field of view, lowest dose settings that you can get away with. And then it should always be prescribed and the entire volume reviewed by a licensed dentist and someone with sufficient training to review the volume. So the phrase that you hear over and over is being justified and optimized, benefits outweighing risks. Those are all related. Justified meaning there's a clinical reason for the scan. Optimized means the smallest field of view and lowest dose appropriate for the question you're asking. Just a quick review of the SEDENTEXCT. So this is from Europe, and you'll see a lot of the principles are really similar to what the ADA recommended. All right, now I want to get to dose and pay close attention to this part. I think dose is even more important than understanding how the machine works. So the unit we use typically is microsieverts, indicated by this micro symbol here. Quick comparison to keep things in mind. This is one I think you should know. It's highlighted. 5 microsieverts is our typical intraoral radiographic dose to the patient, and that's assuming round collimation, which is largely used in the US. You can see we could reduce dose by about 80% if we did go to rectangular collimation. I think most dentists don't realize how much that would actually reduce dose. But on average in the US, we're using these numbers. And so 5 microsieverts, that means for an FMX, 18 to 20 times that. So about 100 microsieverts for an FMX in the US. A panoramic radiograph is going to be about 10 to 20 microsieverts, or on average about 15 microsieverts. And compare that with a CBCT. Of course, these numbers vary widely depending on the field of view, depending on the settings used. But on average, so this is a good number to keep in mind, it's about 100 microsieverts. So about the equivalent of an FMX or about 20 intraoral radiographs. Then just for comparison, multi-slice or medical CT is going to be about 1,000 microsieverts, so that's 1 millisievert. So it's about 10 to 20 times the dose of a CBCT. And then again, just for comparison, we're all exposed to these low doses of radiation constantly just by living on the planet Earth. So in the US, the average yearly annual dose is about 3,000 microsieverts or 3.1 millisieverts. A lot of that comes from radon, but we have radiation from space, radiation from within our own bodies, and then terrestrial from the ground and rocks around us. And that all adds up to about 3.1 millisieverts per year. And this just happens to be the same number on average in the US per person receives about 3 millisieverts or 3.1 millisieverts of medical and consumer radiation. So a lot of that is some patients are receiving a lot of medical CTs, some don't receive any, so obviously this is going to vary between patient. But you can see the dental impact on this is relatively low, only about 7 microsieverts, which kind of makes sense if you think about it. That's a little over 1 intraoral radiograph. So on average, each person gets about 1 bite wing a year, a little bit more than 1 bite wing a year. Not everybody goes to the dentist, and so they don't get that each year, but the people that do maybe get 2 or 4 bite wings, and that gives us our average. And then what you want to keep in mind is that 100 microsievert dose for CBCT covers a huge range. This is a summary table of the different studies that are often cited for CBCT dose. And you notice one is really high up here at 1,073. This is an older machine that's not used anymore. There was a lot of wasted dose, and those doses have come down quite a bit. And so 100 microsieverts for most cases is probably going to be an overestimate. I'd rather overestimate than underestimate. In fact, the settings we use at the school for the most part, it's going to be around 20 microsieverts, so similar to a pano. We don't use the highest resolution, not the highest dose settings. But even within the same CBCT, the settings can make a 10 times difference in dose depending on the machine and the protocol. And so what do you need to know as a clinician? Well, what do you control? You control the field of view. Choose the smallest one appropriate for the question. You control the resolution. Higher resolution usually means higher dose. And so use the lower voxel size, the lower resolution that answers the question adequately. And then number of acquisitions. Try to limit the number of CBCTs you do on a patient. And if the first one is diagnostic, you don't need to repeat it just because something didn't look perfect. And then always follow the principle of ALARA, as low as reasonably achievable. Same principle that applies to intraoral imaging. Justify every scan, optimize every scan. And so here's the practical mindset. If you're considering CBCT for implant planning and your machine does a focused single implant scan at 20 microsieverts, that's probably the low dose setting, then go ahead and use that one. That's this equivalent of about 4 intraoral radiographs or maybe 1 panoramic radiograph. For information that could prevent you from injuring the inferior canal or perforating the sinus, I think that trade-off is a no-brainer. If you're considering CBCT, on the other hand, just to look around without a specific clinical question, well, then the dose is hard to justify. So that's kind of the guideline there. And here's my practical tips for a general dentist thinking about using CBCT. Tip 1, justify before you order. Write down and have in your mind a specific clinical question that the scan is answering, usually that can't be answered in 2D imaging. So if you can't articulate one, you don't need the scan. That's kind of the bottom line there. Tip 2, choose the smallest field of view that answers the question. A single implant doesn't need a full skull scan. Maxillary sinus pathology doesn't need a scan that includes the orbits, and so limit it to what you really need to see. Tip 3 is remember that 2D and CBCT or 3D imaging are complementary. They're not redundant. CBCT is not going to replace bite wing radiographs for caries detection. The metal artifact from restorations makes caries hard to see. It's also a little lower resolution. Keep using 2D radiography where it's the right tool. Specifically, I would say bite wing radiography. Tip 4, if you're not comfortable interpreting everything in a scan, refer it for a radiology read. We talk about legal responsibility for everything in the volume in the 3rd video, and this is real. I've seen too many cases where this has been ignored and things have been missed, and that is an impact to the patient, the patient's families. All right, so that covers what CBCT is, when to use it, and dose. In the next video, I'm going to give you a quick tour on how we look at the data, NPR views, panoramic reconstructions, 3D renderings, talking about ray sum and MIP projections, just enough so you can follow through CBCT cases that I'll show you. So we'll see you on the next one. Thanks.